Okay, so now we're going to be looking at assessing abilities and capacities for sensation. Sensory perceptual skills are defined as actions or behaviors a client uses to locate, identify, and respond to sensations, interpret, organize, and remember sensory events via sensations that include visual, auditory, proprioceptive, tactile, olfactory, gustatory, and vestibular sensations. The purpose of sensory testing is identified below. So we want to assess the type and extent of sensory loss, which will evaluate and document the sensory recovery. This will assist in the diagnosis. We want to determine impairment and functional limitations, provide direction for OT intervention, determine time to begin sensory re-education, determine the need for education to prevent injury during occupational finding, and determine the need for desensitization. So these are some neural pathways of sensory stimuli. This is coming from chapter 9 of Radomski, so if you want more information on this, please refer to that chapter. So now there's going to be a few examples of different injuries and what we want to focus on. This is all in the book, so I know it's very lengthy, but I'll just quickly go through a few key points. So for cortical injury, we want to quickly screen the areas of the body where sensation is likely to be intact, followed by a more thorough evaluation only if a deficit is found during the screening. So we want to assess more thoroughly the areas that are more likely to be affected, which is usually the side contralateral to the injury. If tactile sensation and proprioception are intact, then assessment of temperature and pain is not necessary. And then on the contrary, if pain and temperature are absent, then the assessment of light touch and proprioception is not necessary because those sensations will also be absent. For spinal cord injury, we want to use a test with both pain and light touch stimuli to determine the level of injury. The gold standard for the neurological classification of spinal cord injury is the ASIA impairment scale. We want to apply the stimuli within each dermatome, make sure that we're testing each dermatome bilaterally because the results may differ from side to side. Here is an example of the dermatome distribution. So again, make sure you're testing in every dermatome region as well as testing bilaterally. For peripheral nerve injury, the purpose of evaluation in clients with peripheral polyneuropathy is to establish the impact of the disease on the protective sensation. So we want to choose an assessment of protective sensation. Because functional tests of sensation require object or texture identification are completed with the thumb, index, and middle fingers, these assessments provide information about the functioning of C6 through C8 and the median nerve. So here's the sensory distribution of peripheral nerves. And then these are the principles of sensory testing. Again, if you want more information on these, this is chapter 9 in Radomski. And then here's the same as Weinstein monofilaments table. This just goes through the monofilaments number and what the interpretation and the functional hand function use would be. So now we're going to switch gears and go over to chapter 22 in Radomski. This chapter is optimizing sensory abilities and capacities. So we want to choose an intervention strategy based on diagnosis, prognosis, and evaluation findings. We want to look at the loss protective sensation and the passive sensory training provided for patients who have lost sensation but are expected to regain sensory ability. Sensory re-education is provided for patients who have some sensation and potential for better sensation. So we'll move on. So compensation for impaired or absent protective sensation. These are some compensation techniques. The goal of treatment for patients with diminished or absent protective sensation is to avoid injury. So we just want to make sure that they're not injuring themselves due to the loss of that protective sensation. Desensitization. This is chosen when the sensory evaluation reveals an area of hypersensitivity in which ordinary stimuli produce exaggerated or unpleasant sensations. So this is the hierarchy of texture and vibration used in desensitization, from super soft moleskin all the way up to a Velcro. Sensory training, the goal is to maintain or restore the cortical hand representation and to regain the use of sensation of the hand. This includes active and passive sensory training. So peripheral nerve injury, we have phase 1 and phase 2. Phase 2 re-education begins with the start of reinnervation of the hand, and phase 1 is the phase following the nerve injury before the start of reinnervation. And then for CVA, we found that passive and active are in this as well, on top of using mirror therapy to get that sensory re-education back. So this one is chapter 22 in Radomski if you want to reference this material.
Okay, moving on to chapter 23 in Pedretti, evaluation of sensation and interventions for sensory dysfunction. So first off, we're going to talk about sensation. So sensation is explored in terms of touch, temperature, pain, proprioception, which is a sense of position, and stereognosis, which is the ability to identify things without vision. Effects vary depending on where the injury occurs. So with a CNS injury with brain involvement, with or without spinal cord injury, you're likely to have deficits with proprioception, stereognosis, and processing sensory feedback. With a CNS injury only involving the spinal cord, most likely you'll have a loss of sensation at the dermatome, at the level of injury, and below. And with a PNS injury, you'll have issues with touch pressure awareness and 2-point discrimination. So somatotopic arrangement. Sensory information is arranged somatotopically in the primary somatosensory cortex. So this is a picture of the sensory homunculus. It shows the arrangement and proportions of cortical areas representing the surface of the body. Large cortical representation, like you see in the picture, shows where there's a higher density of sensory receptors. The distal parts of you, so your fingers and your hands, have a higher density of receptors. Neuroplasticity. So the brain has the plasticity to mechanically induce neuronal reorganization. Instances in which this occurs include the processes of habituation, learning, memory, and cellular recovery after an injury. Receptor morphology is affected by hand use, so that concept that we know about use it or lose it. And because there is an overlap of the receptive fields of various nerve fibers, a single stimulus will excite different receptors. So for the somatosensory system, it processes sensory input from superficial and deep sources. Sensation is stimulated by receptors in the PNS, which travel through afferent neurons to the CNS. There's 3 types of receptors: mechanoreceptors, chemoreceptors, thermoreceptors, and each has a subset called nociceptors, which are the pain receptors. Afferent neurons have peripheral axons that carry information towards the brain, and they're categorized by the diameters of their axons. Large diameter axons transmit information more quickly, and those are the things like vibration, light, touch, and proprioception, while your smaller diameter are often unmyelated and carry information more slowly, which is pain and temperature. Disturbances in somatosensation may manifest as paresthesia, hyperalgesia, hypersensitivity, dysesthesia, and allodynia. So your body has dermatomes, which are areas of skin supplied by one dorsal root and its spinal nerve. There's lots of ways to do sensation testing. You can also use a hand grid worksheet to record the data. So specific sites can be used to reflect larger portions of the hand innervated by the same peripheral nerve. And same thing goes with central nerves. There's specific sites on you. To test for pain, you can use the paperclip to do the sharp dull test. Testing for touch sensation, you can either use static 2-point or moving 2-point. Testing for touch pressure, that's where you use those monofilaments. You always want to start with the very finest one, which is 1.65. Proprioception, that is where you're going to hold the client and move the part into flexion or extension, asking them, am I moving you up or down or in or out? Stereognosis, that's something you could use the Moberg pickup test. And lastly, localization of touch. That's important to test to perform after a nerve repair because it helps determine the client's baseline and projected functional prognosis. That's the test where you'll touch them with the finest monofilament that they can feel and having them look away, and then have them look back and point to you where you have touched them.
And so the final chapter is going to be for Radomski 25, Assessments and Intervention for Perceptual Dysfunction. So perception is the gateway to cognition, and it is the mechanism through which the brain interprets sensory information. General principles of OT assessments: you want to make sure that you use batteries that are standardized because they require verbal as well as motor responses. And you want to make sure that you observe the performance within the context, and that you discriminate between impairment in reception and motor or verbal output. And predominantly, you're going to use a bottom-up approach to evaluate visual impairments prior to higher level perceptual skills. Some possible assessments that you can use to measure perceptual dysfunction is the AMPS, the LOTCA, as well as Tulgia's multi-context treatment approach. General approaches to occupational therapy intervention. There is going to be two approaches, mainly the adaptive approach, which provides training to facilitate adaptation, as well as the remedial approach that seeks to produce changes in the CNS. And this one requires multiple practice opportunities so that the person can carry over the performance to other activities, whereas the former, which is the adaptive approach, is mostly focused on repetitive practice of occupational performance. Assessments and interventions. So for each of the different disorders, we have assessments and interventions for them. And so for visual and spatial perception disorders, the type of disorders are figure ground dysfunction, position in space, as well as form consistency dysfunction. And you can take some time to go through the different ways in which you can assess and provide intervention for them. For right and left discrimination dysfunction, there is a condition called stereopsis, and again, you can take some time to review assessment and intervention. There is motor perception disorders such as ideational apraxia and ideomotor apraxia, as well as Jessen apraxia. For tactile perception disorders, there is astereognosis, agraphesthesia. Some visual perceptual disorders are agnosia, color agnosia, and color anomia, as well as prosopagnosia. For visual perceptual disorders, there is the condition recognized as metamorphosia and simultagnosis. And again, take some time to go through the different ways that you can assess and provide treatment for each of these conditions. And finally, you want to focus on the behavioral aspect of perceptual dysfunction. The individual should have some degree of self-awareness and recognition of their disabilities. But at the same time, you have some persons that may present with denial, especially in the early stages of their recovery when they're not as aware of certain deficits that they may have. So you want to work with them to help them to be aware of the disability and recognize and try to provide some sort of help or assistance with their emotional response and assist them in achieving an emotional balance to re-establish their quality of life.